Good morning. I'd like to call this meeting to order. My name is Ann Aiken, and I'm the acting designated federal officer for NVAC. I wanted to take just a quick moment to thank all the members who are here today and in person. We have both joining us, and for everyone for their service on the committee, including Dr. Hopkins, who remains a guiding force for NVAC. With that, I would also like to take a moment to thank our support team who plays pivotal roles in the management of this committee, including Emily Downs, Rebecca Lazaration, Mike Cavonis, Viola Jacobs, and LaForest Dupree. We also have a number of helpers here today, including Tevin Warren, Chloe Loving, Christina Gibbs, Todd Post, Terrence Calhoun, Daniel Ipsum, and Susan Farrell. There are a few things you should know before we get started today. This is a public meeting. It's being recorded. All statements made today are on the record. This advisory council is governed by the Federal Advisory Committee Act, or FACA for short. FACA provides rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups like this one to obtain advice or recommendations. The voting members are special government employees and are therefore subject to conflict of interest laws and regulations, as are all members who work for the federal government. These members previously provided information about their personal, professional, and financial interests. Each voting member's financial interest and outside affiliation has been carefully screened. We do this each year to ensure that everyone complies with federal ethics law. The liaison representatives are non-voting members of the Advisory Council and are not subject to the same FACA rules as the voting members. Additionally, the information provided at this meeting does not necessarily represent the official position of the National Vaccine Advisory Committee or the U.S. Department of Health and Human Services. Mention of products, processes, services, manufacturers, companies, or trademarks does not constitute an endorsement or recommendation by the U.S. government, HHS, or NVAC. So with that, let's go ahead and do roll call. I'm going to take the official attendance and call up each of the names of the NVAC members. Please verbally respond when I call your name. Bob Hopkins.
Present. Glad to be here.
Melanie Butler.
Good morning and present.
Good morning. Tim Cook.
Present.
Good morning. John Dunn.
Present.
Good morning. Jeff Dushin. He mentioned he might be running a little bit late this morning. Chris Arisman. Lynn Friedland. I saw your face a minute ago.
Good morning.
Good morning. Dan Hoff.
I'm here, but I wish I was there.
We do too. Hi, Dr. Hoff. Molly Howell.
Present.
Hello. Jewel Mullen.
Good morning.
Good morning. Stephen Rinderknecht.
Present.
Hello. Robert Schechter.
Present.
Geeta Swami, I think, is joining us a little bit later today, but are you on, Geeta? Okay. Bob Swanson.
Present.
Roxana Deba. Oh, and I see Dr. Jushin. Hi. We've got you down. Roxana Deba.
Present.
There we go. Good morning. Chris Riegel. Claire Hannon.
Present.
Hello. Rebecca Coyle.
Present.
Good morning. Sheen Good.
Here.
Good morning. Meredith Allen.
Present.
Hello. John Douglas.
Good morning. I'm present.
Good morning. Good morning. Aaron Henry. Or Carrie Robinson.
Good morning, present.
Oh, good morning. Sheena Harris.
Good morning, present.
Good morning. Robert Johnson.
Present.
Morning. Ram Kapaka.
Present.
Good morning, Ram.
Good morning.
Mary Beth Hans. Lamone Collins.
Present.
Uzo Chikwama.
Good morning, present.
Good morning. Barbara Mullock. Troy Knighton. Oh, Troy's sick today. Did I miss anyone? All right, with that, I'm going to go ahead and introduce the Assistant Secretary for Health, Dr. Rachel Levine. She's going to provide us with opening remarks today. For those of you who do not know her, Dr. Levine serves as the 17th Assistant Secretary for Health. Dr. Levine is also the Director of the National Vaccine Program, and she champions immunization every day. She's been working very hard to overcome the COVID-19 pandemic, respond to the monkeypox emergency, and overall build a stronger foundation for public health in a myriad of ways. She leads by example, and yesterday she tweeted about getting her updated COVID-19 vaccine while in North Carolina. She also gave a special thank you to all local health departments helping Americans across our country get vaccinated. She travels frequently to represent HHS and looks for ways to make new connections and work together in a variety of ways to improve the health and help people. Admiral Levine, please share your comments with us today.
Well, thank you so much, Anna. I'm really pleased to join you again today in person to provide opening remarks. And I'd like to welcome all of you, the NVAC members, our speakers, and others watching this meeting in person and online. Actually, we're still getting used to this hybrid environment. I'm sitting at my desk looking at the invitation and complaining to my aide-de-camp that there's no link. And she pointed out, well, it's downstairs. So it's like, oh, okay. So here I am. As Ann mentioned, I have the honor of leading the National Vaccine Program. And, you know, I think I've spoken to this before, but it's so important to me to do this as a pediatrician and adolescent medicine specialist. So I know firsthand through 40 years, actually, since I finished medical school, about the importance of vaccinations, the importance of immunizations. And we can see that now with the COVID-19 pandemic and with the immunization program to prevent the spread of monkeypox, but also the critical importance of childhood vaccinations and getting caught up with childhood vaccinations. There's a lot going on in the vaccination space. And I want to thank all of you who work every day so hard to build stronger foundations for immunizations. I really have called immunizations one of the medical wonders of the 20th and 21st century. Today's date marks the start of the fall in the Northern Hemisphere. And as nightfall begins to arrive earlier and we start to order pumpkin spice more often, I actually don't, we are ready to utilize some of the most effective tools that we have in public health, vaccines, to prevent diseases such as COVID-19, influenza, monkeypox, and of course, polio. In terms of COVID-19, our plans this fall focus on making sure Americans continue to have equitable access to our safe and effective vaccines and boosters. As you know, we recently announced a plan to get Americans their updated COVID-19 vaccines this fall, their booster this fall. As Ann mentioned, I received it yesterday. This plan includes offering the new updated COVID-19 vaccines for free. We are standing up new community vaccination centers to further increase access. Over 90% of Americans are able to find a location on vaccines.gov within 5 miles of where they live. We're working with the providers to increase the number of walk-in appointments, as I did, and convenient times for working families, including weekends and evenings. An important part of this is to increase our ability to protect those at most risk, including immunocompromised individuals and older Americans. For example, the Administration for Community Living will help older adults find information through their existing elder care locator and will connect people who face barriers leaving their homes to local services that can help them. And to supplement vaccine protection, the Centers for Disease Control and Prevention have provided guidance on the use of pre-exposure prophylaxis for those who are moderately to severely immunocompromised. So we need to remain vigilant. We have made so much impressive progress in our response to COVID-19, but we need to remain vigilant as we prepare for potential surges potential new variants, more letters of the Greek alphabet to learn during the COVID-19 pandemic. But we have made impressive progress, and I'm so proud of our ability to better manage this disease and our ability to reduce deaths from it. As we continue to make progress in COVID-19 vaccinations and other preventative actions, we need to be responsive, again, to this unpredictable virus. I want to thank NVAC for their leadership in this area and to encourage you to search for gaps, find where the gaps are for us, and underscore our lessons in your work to encourage innovation in immunizations. Now, amidst the COVID-19 pandemic, we have not lost sight of other diseases that affect our nation and the world. Earlier this month, President Biden signed an executive order to launch a national biotechnology and biomanufacturing initiative that will work to build stronger supply chains, expand domestic biomanufacturing, and train a new generation of biotechnologists, among other goals. HHS plans to foster innovation and medical breakthroughs, including in its immunization efforts. So your work providing recommendation, advancing innovation in immunizations is very important. Encouraging innovation is also part of the Cancer Moonshot, an effort commemorating the 60th anniversary of President John F. Kennedy's moonshot speech at Rice University, committing to put a man on the moon and bringing him back. In his memory, President Biden proposed his own bold vision for another American, quote-unquote, moonshot, ending cancer as we know it. This moonshot will also require major scientific and societal advances and strategic use of previous breakthroughs, such as the HPV vaccine, a cancer prevention vaccine, which can prevent 7 kinds of cancer, and the hepatitis B vaccine, which can help prevent liver cancer. Preventing cancer is an amazing accomplishment, and it's essential to the goal of the cancer moonshot of ending cancer as we know it. Along the way, we expect to see many advances in the prevention and treatment of cancer that can be applied to other diseases as well. And so this brings me to one of our newest challenges, which is monkeypox. One of my top priorities is to support this whole of government approach to responding to the monkeypox outbreak. The White House and the administration are working very closely with public health officials and other key stakeholders to ensure that people who are at risk get the vaccines that they need and get the tests and treatment that they might need. HHS has significantly expanded the number of vaccination locations nationwide, aiding the delivery of medical countermeasures to communities at greatest risk for infection. Recently, we announced that we will provide approximately $11 million more for the first U.S.-based fill and finish manufacturing of the Jynneos vaccine. Additionally, the HHS Administration for Strategic Preparedness, ASPR, awarded a contract to expand the distribution capacity of the Strategic National Stockpile. This will better support jurisdictional needs by increasing the number of weekly shipments and delivery locations. So you're going to hear more about this work in the ongoing weeks, but I want to highlight our work in terms of the importance of vaccinations for monkeypox. And one of the keys is to bring that health equity lens that we always bring to our work to this vaccination, and the intersectionality of health equity is critically important. Now, talked about being fall, so we have to think about flu vaccinations. I want to mention that Americans who wish to get a COVID-19 vaccine and a flu vaccine can do so at the same time in the same place. For the 2022-23 flu season, as with other seasons, there are a number of vaccine choices available. If you are 65 years of age or older, there are 3 vaccines that are specifically recommended for you this season. Vaccine manufacturers have projected that they will supply the United States with as many as 173.5 million to 183.5 million doses of influenza vaccines for this season. Now, these projections may change as the season progresses, but we will continue to support manufacturers as they produce this life-saving vaccine to protect us during this flu season. We will be promoting seasonal flu vaccination, and we'll emphasize the importance of flu vaccination starting, as we have done already, in September and for the entire flu season. Our communication outreach prioritizes people who are at higher risk for developing severe complications from flu, such as those with underlying conditions, children, pregnant people, as well as racial and ethnic minorities who experience higher rates of influenza. In addition, as part of its new Partnering for Vaccine Equity program, the CDC has provided more than $150 million to provide national, state, local, and community-level partners working to increase confidence in COVID-19 and flu vaccines among adults in racial and ethnic minority groups. Now, while we respond to public health emergencies such as COVID-19 and monkeypox, we must remain steadfast in the prevention of other infectious diseases such as influenza. Influenza is still a threat, both in terms of seasonal spread and when a new influenza virus emerges. It's always changing, and the potential exists for novel viruses, such as ones that were responsible for the 4 influenza pandemics that had happened in the last 100 years. Our preparedness activities include working with public health partners to monitor influenza virus, both those that circulate in humans and in animals, to know what and where the viruses are spreading and if they're causing illness. So it's a critical aspect of all of our work and the CDC's work. So you'll hear more about the work by the USDA in terms of monitoring bird flu later today. So thank you very much for your time today. I appreciate your dedication and your commitment to NVAC and to vaccinations. I look forward to hearing more from our team about your meeting today and want you to know that your expertise and your work and your dedication is absolutely invaluable to me and our team, to HHS, and really to the health of everyone in America. So thank you very much, and I will now turn to Dr. Hopkins to provide the chair as well. Thank you.
Well, good morning. Thank you, Dr. Levine, for your thoughtful remarks. I also got my boosters this week. No sore arms here, and hope all of you are here with me, both flu vaccinated and COVID boosted. I join Admiral Levine in welcoming everyone to today's meeting. I'd also like to thank the NVAC members and the subcommittee members for their dedication to further the work of this committee. I look forward to the presentations and discussion today and tomorrow. Before I get started, I want to thank the NVAC team for their help throughout the year and in preparation of this meeting. Ann and her team do tremendous work, put a lot of hours in, dedicated time that none of us really see and appreciate until we see the meeting come together. And so thank you all again for your efforts. Let's start with a few housekeeping items. Then we can move to the review and approval of the meetings from the June 15th, 16th, 2022 meeting, followed by a high-level overview of the agenda. In terms of housekeeping, I want to make sure everyone's aware that this is a public meeting. It's being webcasted on the HHS website. For our virtual members, please mute yourself when not speaking and don't use your camera unless you're presenting, asking questions, or answering a question. For the members in the room, please raise your nameplate to stand on its side to indicate you'd like to raise a question or make a comment. During discussion, I ask that all members and speakers identify themselves before speaking if I didn't acknowledge you by name, giving you the floor. This helps the note taker and others to follow along. Throughout the day, there will be opportunities for committee discussion. I'd like to ask, if you would like to ask a question or provide a comment, send me a message through the chat feature, please. Let's now turn to approval of our meeting minutes from our June meeting. The NVAC members previously received the minutes from the June 15th, 16th, 2022 meeting. Do any of the members want to make corrections to the minutes from our June meeting? Hearing none, I'd like a motion to approve those minutes.
Move to approve the minutes as written.
Thank you, John Dunn. Do I have a second?
Second.
Thank you, Tim. I think given that our blended meeting, if there are any objections to those minutes, please indicate so, either verbally here in the room or through the chat feature. See no comments coming through the chat and no objections in the room. We will stand approved. Thank you. Next, let's turn to the topic of public comment. As always, members of the public can provide a public comment by phone about 4:45 today and 2:45 p.m. tomorrow. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request space for public comment during this meeting has passed. However, anyone can submit a written comment up to 3 pages in length to NVAC at HHS.gov. I want to spend a moment or two reviewing the agenda for today and tomorrow. We have a wonderful lineup of speakers. Today, we'll start out with a report from our Vaccine Confidence Subcommittee by John Dunn, who's our chair. We'll then hear from 2 panels on polio and monkeypox, as well as a session on avian flu monitoring. After lunch, we'll hear presentations on the development of universal flu vaccines. We'll then have a panel on vaccines used to reduce the risk for dementia, and the final panel on COVID-19 mortality. We'll conclude the day with our federal agency and liaison representative updates and public comments. Tomorrow, we'll host several panels focused on the safety of available vaccines. First, we'll have a panel on innovations in vaccine safety data. Next, we'll hear from experts around COVID-19 vaccine safety, followed by a panel about monkeypox vaccine safety. Just before lunch, we'll hear from an expert at CDC about evaluating evidence to address vaccine safety concerns. Excuse me. After lunch, we'll resume the panel about COVID-19 vaccine boosters and a panel about protecting rural Americans by addressing gaps in the COVID-19 vaccine coverage. And the day will conclude with public comments. Finally, a reminder for our 2023 meeting dates. Our next meeting will be February 2nd and 3rd, 2023, followed by meetings on June 15th, 16th, 2023, and September 21, 22 of next year. Please refer to the NVAC website for final details on these upcoming meetings. At this time, I'd like to start our first presentation of the day from Dr. John Dunn, who will provide the Vaccine Confidence Subcommittee report out. Thank you all for joining us for NVAC today.
Good morning, all. And thank you very much. Thanks in advance to everyone on our committee and everyone on our subcommittee who's put in all the work necessary to produce the version that we have for you today. You'll all recall that we reviewed an earlier draft of this report at our last meeting in June, I believe. And we took away several comments and suggestions from that, as well as some revisions afterwards. Those of you who've had a chance to review the final document that we're presenting today will note that we've incorporated some of those suggestions and revised the document accordingly. It's also been revised in a few other ways that have made it clearer, more succinct, and more tight to read. The overall tone, thrust, and set of recommendations have not changed significantly. I want to go through those again today. I will spend less time on them than I did last time, except in the case where we've made some changes. I do want to start by just level setting and talking and reminding everyone of what exactly our charge was. What our charge was from the ASH with writing this report. The report was to describe the determinants of vaccination confidence along the lifespan, to make suggestions as to what HHS can do to improve confidence in all recommended vaccines, and to provide guidance on the utilization of evidence-informed best practice from a variety of research fields. The purpose was that this working group should synthesize and summarize existing evidence and applicable research that addresses vaccine confidence, as applicable to age groups and specific vaccines, and particularly focusing on the period since 2015, which was the last time that NVAC did this process. We were also to produce a document that recommended new and implementable strategies and approaches for sustaining and increasing confidence across the lifespan. Before reviewing the recommendations, I did want to talk briefly about confidence itself and our definition thereof, because this is something that has come up often in conversations, both in the subcommittee that drafted this report and among NVAC members. And so I want just briefly to go over again how we arrived at the definition of what it is that we're working on. There are several terms that get thrown around with vaccination, including confidence, hesitancy, refusal, uptake, coverage, and all of these are nuanced. They are actually different things, and they refer to different aspects of vaccination and immunization in general. The definition of confidence reflects, in many ways, it reflects the specific element of overall vaccine-related behavior that we're examining. We cut this up in three ways as attitudes, intentions, and behavior. Attitudes reflect the way that individuals think and feel about something, and confidence is really referring to that. Where vaccination is concerned. Intentions, conversely, are your actual motivation to do something, such as get vaccinated. And when we talk about hesitancy, which is different than confidence, that's really what that's referring to. Behavior, on the other hand, is what you actually do. And that includes refusal, delay, uptake, coverage, and things like that. All of these, of course, are intertwined in certain ways, and even the three domains that I just discussed are not independent in and of themselves. That is, behavior within a community or population can ultimately modify attitudes, which may further modify intention. All that said, confidence itself, which falls into the domain of attitude, has several dimensions. You know, vaccines as being a good thing, by which I mean beneficial or important or effective, versus vaccines as a bad thing, you know, safety, whether they cause harm, lead to side effects, and vaccination as a whole as being a trustworthy endeavor. And people's attitudes about that really include their attitude toward their providers, clinics, vaccination manufacturers, and vaccine oversight. For the purposes of our report, the definition of confidence, which is really what we're working with here, is a belief that vaccines work, that they are very safe, and that they are part of a trustworthy medical system. And this is a definition that's consistent with what's used by the CDC and the World Health Organization. Let's see. That worked. Excellent. So our recommendations, as you recall, were cut up into 5 sections. These are the same as the sections that you saw last time. As I go through each of the recommendations, I'll briefly touch on them. You'll note that there are some words that are highlighted in blue. That's to remind you about changes that we presented last time that I reviewed the report with NVAC. And there are a few things marked in red, which are new changes to the recommendations that we've made since that time. Our first section is on investing in vaccine confidence research and data. The recommendations in here are very much the same as what we'd reviewed the first time around. Recommendation 1.1 that the Assistant Secretary of Health should convene an interagency work group to identify and describe all vaccine confidence research that's funded by HHS and its partners, provide this information publicly, and develop a scientific research agenda to address additional gaps. And that's intact from the last time that we discussed it. 1.2, that Health and Human Services should facilitate and fund research and data collection with the purpose of assessing vaccine confidence in subpopulations. And you see here it's listed above for specific ACIP recommended vaccines. The populations we're talking about are the ones that you'd expect, including Native Americans, Alaskan Natives, Asian Americans, Pacific Islanders, lesbian, gay, bisexual, transgender, adolescents, young adults, people with chronic conditions, and those living in rural communities or other areas that have higher than average or unique vaccine confidence values. All of these things we recognize now impact in the end whether people get vaccinated or not, and it's important to be able to collect data in such a way that we understand what we're dealing with any given group. Recommendation 1.3 that the Assistant Secretary of Health should facilitate the timely assessment of vaccine confidence in each of those subpopulations. The idea being that the CDC should then publish and make available trend data in these populations to measure, so that we can measure our progress. Recommendation 1.4, that the CDC should evaluate the impact of the COVID-19 State of Vaccine Confidence Insights reports. This should be evaluated with internal and external stakeholders, and they should consider expanding these reports for each routinely recommended vaccine in the United States beyond the COVID-19 vaccine. And finally, in this section, the ASH should fund additional research to improve our understanding of what works, to improve vaccine confidence in individuals who are questioning vaccination or those who are low to moderate in the vaccine hesitancy continuum. The investments that are needed in large cross-sectional surveys of adolescents and adults using standardized measures would enable researchers to actually more consistently be able to identify changes over time in vaccine-related knowledge, attitudes, and confidence, and also really examine these by subpopulation. Section 2 involves building trust in government and the vaccine enterprise. You'll see that we've made adjustments to a few recommendations in this section. Remember, the importance to building trust in government lies in the fact that this turns out to be strongly correlated with actual vaccine behavior. The 2022 Edelman Trust Barometer Special Report on Trust in Health found a 21% difference in vaccination rates between those with higher and lower trust scores in the health system, including the government's role in it. If we don't address this, we're not going to effectively be able to address the problem. Recommendation 2.1, that HHS and other federal agencies and partners should continue to disseminate evidence-based information about vaccines, vaccination, and vaccine-preventable diseases. And we specifically call out that this should include information about vaccine safety and effectiveness that's transparent and timely. And so this has been expanded, as you can see, to include other partners beyond HHS, which will really be necessary. Recommendation 2.2 was new last time, involves ensuring that vaccine safety and confidence funding doesn't become stagnant. And doing that means that Congress and HHS and other federal agencies should continually assess the funding situation. Recommendation 2.3, during vaccine preventable disease outbreaks, HHS should continue to proactively respond so that they are first, right, and credible. This is fairly self-explanatory, but emphasizes the fact that whoever gets their message out first often sets the agenda for the conversation. And it's become obvious that it's critically important that we need to have our messages on outbreaks of disease out immediately with the vaccine before someone else gets their message in there and we're playing defense. Recommendations 2.4 and 2.5, you can see here, CDC and FDA should increase the dissemination of vaccine safety and efficacy data and information. HHS should also develop a list of the vaccine confidence information and education activities that were funded from Section 2302 of the American Rescue Act in 2021, and should also provide an overview of what was learned from these activities. This should be available for care providers for research and for the general public. Our third section involved educating and empowering healthcare providers. There are not significant changes to this section, certainly not to the content. Just to recall, research shows that healthcare providers are the main influencers of vaccine decisions. Really, functionally, they bridge the gap between healthcare policymakers and patients, and they can influence patients' vaccine decisions. Excuse me. Recommendation 3.1, that Health and Human Services should evaluate the effectiveness of current messaging and media strategies on improving vaccine confidence among healthcare professionals, and then disseminate tested messages. There is actually curricula that's been developed for that in 2015, but most schools only offer a few hours of teaching, which means that most healthcare professionals are not necessarily adept at having these conversations. Recommendation 3.2, HHS should work with partners to provide healthcare professionals with training to recognize and reduce racism and discrimination, and with evidence-based ways to disseminate information to improve confidence in people who lack trust in the system or their provider. And just to emphasize, the training should establish criteria for the appropriate inclusive delivery of vaccination services. Recommendation 3.3, HHS should continue to work with healthcare professionals to improve the quality and strength of healthcare professional recommendations to influence confidence in vaccine. This involves things like the presumptive announcement style language that we use for HPV vaccine. 3.4, HHS should continue to engage a variety of professional organizations and healthcare professionals with easy to understand information about vaccine recommendation changes. I won't dwell on that. Any of you who are responsible for communicating these broadly understand what a challenge it can be. Recommendation 3.5, that HHS should work with medical, nursing, pharmacy, dental, and alternative medical schools, as well as residency and training programs and licensing boards, to assess what vaccination content currently exists in their education or training programs or on their certification and recertification exams. The follow-on to that is, of course, that HHS should then develop evidence-based curricula or exam questions to enable clinical professionals to be up to date and to be able to pass their information on to others about how vaccines work and about how to recommend them to patients. Recommendation 3.6. HHS should develop or fund the development of vaccine confidence training for students in other healthcare schools or settings. And this would include nursing home aides, community health workers, et cetera, to provide strategies and information to make a strong vaccine recommendation and to improve confidence in vaccines and vaccination. This is really just in recognition of the fact that consistent messaging from all members of a healthcare team is crucial to getting building confidence in vaccines and actually getting vaccination done. Our fourth section involves fostering community engagement and education. This really reflects the fact that vaccine decision-making is informed both by the identity of the social group or community that a person belongs to and by its practices about gathering and processing information. Fitting in with social norms plays a big role in how people behave with vaccination, and these recommendations address that. You'll also find there's no significant changes to these recs from the last time around. 4.1, that HHS should create a new collaboration and nurture existing partnerships with a variety of community organizations to bring different perspectives into vaccine discussions and engage diverse communities to share information, tailor immunization activities, and create community-based strategies. You'll see things that relate to this all along the way. The need to tailor vaccine messaging is almost certainly a crucial element of what we need to do here. In addition, HHS should fund, evaluate, and publish findings on community engagement. Focusing on vaccines for which it is less clear about the role that the community plays in improving vaccine confidence, such as tetanus vaccine or shingles vaccine. And obviously, the findings from these evaluations should be woven into practices and into policy efforts. 4.3, that HHS should work with the Department of Education and other educational partners to develop or fund a curriculum for middle school students to teach them about the value of vaccines and how they work and about the strong safety profile that they have. This curriculum should also ideally teach middle school students how to assess the credibility and reliability of sources from which they get such information, and to teach them how to distinguish evidence and scientific dissent from scientific denialism. Our final section relates to advancing communication strategies to increase vaccine confidence. And again, this reflects the need for strategies to be tailored, targeted, and timely to specific vaccines and specific subpopulations. For many years, our work in this area really was geared towards a one-size-fits-all model, and it has become increasingly evident that that's inadequate to address the challenge we have before us. 5.1, the Assistant Secretary of Health should ensure that HHS utilizes American Rescue Act funds to provide culturally and linguistically appropriate communication materials. Materials should be tailored, content-specific, and tested to ensure that they're useful to the audience, that they increase vaccine confidence, and that they do not include images with needles. In particular, we really encourage using communication strategies to advance community-based influence. Things like storytelling, use of gist, emotive anecdotes, and imagery. 5.2, HHS should identify and increase the use of trusted messengers in the community and social media influencers to help disseminate information and share pro-vaccination narratives. This is unchanged from before, and really it reflects the fact that these are the folks who are most likely to be able to reinforce or change the social norm around vaccination. If we can change social norm in a community, that's probably going to be one of our most effective steps at changing the way people actually behave. Recommendation 5.3, that HHS should evaluate the feasibility of developing community-driven responses to myths, misinformation, and disinformation about vaccine-preventable diseases and vaccines to educate the public so that they can make informed decisions. Once again, this reflects the fact that studies have shown that tailored materials have a greater impact on positive vaccination intention and attitudes. 5.4, as people pay more attention to negative information, the ASH should convene a meeting of experts both in and outside of HHS to develop, fund, and implement a comprehensive strategy for addressing misinformation and disinformation in a timely and persuasive manner. That's a short recommendation that involves a big lift. And again, it reflects the fact that both the type of messaging matters and that there's a need for us to better understand the major sources of anti-vaccine disinformation and how they operate. Recommendation 5.5, for purposes of increasing trust and reach of science-based information, HHS should fund or develop training for healthcare professionals on using social media communication. This is the way that things are communicated today, and we need to be able to do that. Training should provide strategies for patients and other community members on these platforms and ways to better leverage social networks to deliver our message. Recommendation 5.6, we've adjusted with additional specifics. The Assistant Secretary of Health should convene high-level meetings with health experts and national security experts for the purpose of assessing vaccine misinformation and disinformation ecosystem. In these meetings, participants should identify sources, dissemination tactics, finances, and actors. And the purpose to that is to identify ways to combat dangerous and inaccurate information, as well as hate speech related to vaccination. It's going to be essential for us to convince social media companies and many others to identify and flag potentially harmful misinformation. And this is one of the steps that can enable us to begin that. I wanted to make sure we left time for the committee to discuss and bring up their thoughts and suggestions about what we're doing. I think I don't have anything up here where I can see that, so I'm going to ask Ann and Bob whether anyone has comments that they'd like to make.
Thank you, John. Nice summary of a lot of hard work by this committee over the last couple of years. I think it strikes me as we've gone through this process, I think we've recognized over the years that there are lots of misinformation and disinformation streams that have affected vaccine confidence in our population. But it's become more and more evident how much of this is gone beyond just the internet to social media to development of community biases that are going to require ongoing efforts for us, both in our healthcare settings and in the community. I want to thank the committee for their hard work in these efforts. Are there any questions or comments from either those in the room or any of our committee members online? Dr. Dushin, I understand you have your hand up.
Carrie Robinson also.
All right, Jeff, if you're having trouble with your microphone, we'll come back to you in just a moment. Carrie Robinson has her hand up.
Is it working now?
Oh, there you go, Jeff. Please go ahead.
Okay, great. I just want to thank Dr. Dunn and the folks that work putting this detailed report together. It's going to be tremendously valuable. I wanted to ask whether the committee discussed the potential inclusion of a more explicit acknowledgement and need to address systemic racism in healthcare and implicit bias in medicine. I mean, clearly, trust is the fundamental requirement for vaccine confidence, and that means not only trust in the product, but the medical system and trust in government. And we know that from our experience with COVID, for example, our communities have a lot of concerns and dissatisfaction with being approached with a categorical issue that may be related, let's say, to an outbreak response, when they perceive that on an ongoing basis, many of their own needs and priorities are not acknowledged or addressed by said authorities. So I was just wondering if there is a place to sort of acknowledge that and understand the importance of relationship building with community, sustainable and dependable resource commitment to empower and engage communities to understand their view of not only vaccine confidence, but their view of health and their needs and concerns around health conditions in general and where immunizations and vaccines fit in. So again, I just want to thank you for this report and considering this comment. Thank you.
Yeah, thank you, Jeff. That's an extremely important thing to have brought up. We did discuss and address this. Do you guys have the section number? I don't have a copy of the report.
Section recommendation 3.2. If we could come back to that.
Let's see. There we go. Yeah, this is probably best contained in here. There's some additional there's additional commentary about this in the front end of the report because it is something that we did discuss. It's as you acknowledged, Jeff. It's that's a big broad issue that goes well beyond vaccination. It was intended that this recommendation be the place where that could be considered and addressed. It's our additional comment on it was the that the training should establish criteria for what inclusive delivery means, involving respectful treatment and outlining ways to provide effective assessments and provide lessons from inclusive facilities. There's again in the front section of the report, and I can't recall precisely where we talk a little more broadly about this.
Page 10 in the report has a great deal. Yeah.
Excellent. Thank you.
All right. Thank you, Dr. Duchin. Our next question comes from Carrie Robinson online.
Good morning, and thank you for the opportunity to participate in this group. We really appreciate, from a Canadian perspective, the comprehensive and multifaceted actions and recommendations that are reflected in the report, that really well developed and does align with our experiences in terms of what we're seeing as some of the key factors and the best practices that we're identifying, in particular to take sort of the diverse, community-based approach and the power of trusted leaders that aren't healthcare providers as well. So that might be something I don't want to make too many, recommendations for change, but just the empowering of other leaders in diverse groups and sectors, whether faith-based, cultural or otherwise, has been quite powerful in Canada. I think I see great value in this report in terms of highlighting the range of evidence and knowledge that we need to consider and synthesize to inform our actions. And one aspect to maybe consider is the value of lived experience and lived and living experience as a source of knowledge to really understand the cultural, behavioral barriers or factors that affect vaccine confidence. And just to pick up on the important points here reflected around sort of health literacy, recognize that there's a recommendation reflected about curricula for middle school students. But I think it might be important for us to consider broadening that, across the childhood life course and experience from the earliest years, but also be thinking about this with our broad public health partners beyond vaccination. We know that health literacy and the ability to detect what is, factual and credible information is really key for so many different health behaviors. So I think there's an opportunity for us to link this a little bit more broadly, but just to congratulate the committee on the exceptional work on this. We'll certainly be drawing on this report as well for our efforts in Canada.
Excellent, thank you. And I would echo your comments. It's As with Dr. Duchin's comments, what we're seeing here really reflects the things that are a challenge here are also things that cause a challenge with many other aspects of healthcare and healthcare delivery.
And many of those aspects that Carrie has brought up are addressed on page 18 and around recommendation 5.1.
Thank you.
I have a comment in the room from Steve Renderneck.
Yeah, no question. Just a comment. You took on a massive undertaking. I mean, the erosion of confidence in vaccines is huge, and I like the detailed report and the comments that have been made. One thing that really struck home with me was how things have changed over the years, at least in my practice. There's always been anti-vaccine people, okay? But as I look, particularly over these past 2 years with COVID vaccines, the kids in my office who are not receiving this vaccine, they've had all their other vaccines. You know, they're well vaccinated. They're not anti-vax people. So the distrust goes deeper into almost a lack of confidence in established institutions in government, in industry, and to some degree their own healthcare provider. And so that's what's, I hope that doesn't expand into other vaccines as time goes on, but I was really happy to see that addressed and discussed in this. So good work. Thank you.
Good. Thank you very much. I also wanted to take the opportunity to extend my thanks to the subcommittee that we had that put this together. It included several members of our NVAC team here, along with several other outside experts. And there's an enormous amount of time and thought and dedication. This was not a committee that required much effort to get a lot of input out of.
If there are no additional comments or questions, can I get a motion to approve this report?
I motion to approve the report.
Thank you, Rob Schechter. Do I have a second?
Second.
Thank you, Steve Renderneck. And as we did with our previous effort, if there are any objections or concerns in the room or online, please note those verbally or in the chat online. I see no objections on the chat. Can I see a raise of hands for those that vote approval in the room? Oh, I'm sorry. Anne's going to call this verbally. Thank you.
I'm going to go ahead and call names and ask you to say if you approve the report, yes or no, or you can also abstain. Robert Hopkins.
Vote for approval.
Thank you. Melody Butler.
I vote to approve.
Thank you. Tim Cook.
Yes.
Thank you. Jeff Duchin.
Approve.
Thank you. John Dunn.
Approve.
Thank you. Chris Arisman, if you're on. Lynn Friedland.
Approve.
Thank you. Daniel Hoff.
I approve.
Thank you. Molly Howell.
Yes.
Thank you. Joel Mullen.
I approve.
Thank you. Steve Renderneck.
Approve.
Thank you. Rob Schechter.
Approve.
Thank you. Rob Swanson.
Approve.
Thank you. So with that, we have approval. With 12 yes votes, 0 no votes, 0 abstains. We do have 3 members that are absent today.
Great. Thank you very much, Ann. And I want to once again laud the work of this Vaccine Confidence Committee led by John Dunn. Thank you all for your great efforts to get this report out, and we'll get this forwarded to the Secretary.
Thank you very much, everyone.
Our next panel is, we'll start here in just a moment, progress on emerging threats in polio eradication. With the first case of polio in the U.S. in almost a decade, this panel will explore progress that's being made and the threats to that progress. Our panel will consist of Dr. Peter Salk from the University of Pittsburgh and the Jonas Salk Legacy Foundation, presenting on overview and meaning behind polio case and wastewater data. He'll be followed by Dr. Patricia Schnabel-Rupert from the Rockland County Health Department, about the recent case in New York. Then Dr. Stephen Wesselak from the Centers for Disease and Control and Prevention on global eradication and COVID-19 data, followed by Dr. David Oshinsky from New York University speaking about vaccine hesitancy. And we'll give the floor to Dr. Salk if you're here in the room.
HHS grateful.
And for those speakers that are in the room, if they want to come to the table at the front, we'll make our changeover a bit easier.
Good morning. Thank you so much for having me. I'm looking forward to making a presentation, and I want to be sure that I'm being heard and also that I know how to work this clicker as far as the slides are concerned. Is it the, I guess the forward and the back buttons and pointing this way? Okay, fantastic, good. Okay, I'm here today to be speaking not so much as a deep subject expert as rather someone who's had an investment in this field for many, many years, starting in childhood, and has been following the eradication program to some extent. And I'd like to share my own personal perspective about my experiences. This was me at 9 years old, getting the second polio vaccination with the experimental polio vaccine that my father and his team at the University of Pittsburgh had been working on. I don't know how I mustered that kind of smile. I hated needles and had just gone through a very painful blood drawing procedure where the nurse couldn't find my little veins. In any case, let's take a little bit of a look at what has gone on in over past decades with respect to polio vaccines. As we know, there are two general categories of polio vaccines that have been in use. One is the inactivated non-replicating polio vaccine that my father and his team worked on, and others, and also the oral vaccine with using a weakened live attenuated virus that was Dr. Albert Sabin's preferred way of going, and others that were working in that field as well. The inactivated vaccine, the initial one that my father and his team had developed, was introduced for use after an extensive national field trial involving 1.8 million school children. It was approved for use the same day that report was made by Thomas Francis Jr. at the University of Michigan, who had analyzed the data. And so that was in April of 1955. We'll look at the results of that introduction, but just to say that shortly after that vaccine had been introduced, it was about 7 years later, the oral vaccine was introduced, and it came along with a lot of hype about the superiority of the live vaccine approach. It had long been a dogma that the only way to immunize effectively against viral illnesses was using a live immunogen so a person could experience an active infection. So that dogma was the basis of a lot of hype. I'm going to be somewhat candid in my communications. When the live vaccine subsequently was introduced in 1961, it was supposed to be superior in every way, more potent, higher levels of immunity, longer lasting immunity, you name it. The vaccine, of course, was less expensive to produce, much easier to administer on sugar cubes or drops in the mouth, and has been the mainstay of the global eradication program in areas of the world where there's less wealth and so on. But we can go into that. But just to look at this first slide, this is looking at the immune response, the serum responses to the inactivated vaccine on the left and the live vaccine on the right. And basically, the only differences are where the yellow arrows are. One of the points that Dr. Sabin had made is that there would be better intestinal immunity induced by the live vaccine. That's absolutely correct, and you're seeing those differences reflected in the nasal and the duodenal and IgA responses. So that's a major difference between the two vaccines. This chart shows the results after the inactivated vaccine was introduced. Within 7 years, there was a 97% reduction in polio in this country compared to the 4 years prior to its introduction. The live vaccine was introduced in 1961, again with a lot of hype as being the savior for everything. Yes, the slope continued downwards, nothing magical seen. If we look at Sweden and Finland, that never used a live vaccine, they only used an inactivated vaccine. Within 12, this is now on a log scale, within 12 years, 0 polio, you could not detect virus in the sewage. So that's a demonstration of some sort about the potential efficacy of the inactivated vaccine approach. If we look at the United States, same thing, log scale, introduction of the inactivated vaccine, linear decline on the log basis. Then the live vaccine introduced, that's the last 3% on the bottom half of the slide, continued down at the same rate, nothing magical. But we see another line there, which is the vaccine-associated paralytic polio that was seen from the very beginning in this country. Children getting polio after being administered the live vaccine or their close contacts, mothers changing diapers, etc. And that continued for many years. This is a chart that depicts that. This is total polio in the line and cases of polio except for imported cases. And at the bottom in the hatched bars are the vaccine-associated polio cases, persisted throughout the period since the introduction of the oral vaccine. This is a chart from the website of Vincent Racaniello. Same thing, except extending beyond the time at which a decision was made to stop using the live vaccine. I should say that I don't have a laser pointer, but during that period where the naturally occurring polio, the wild polio caused by wild polio viruses, had declined down to essentially almost to baseline, the live vaccine came in and replaced the inactivated vaccine in this country. You could not even get the inactivated vaccine. There was no informed consent. Parents were not told there was an alternative. They weren't told that the live vaccine could cause polio. For most people, that didn't matter at all. If you were one of the kids who got paralyzed, if you were one of the parents who was paralyzed because of the vaccine-associated cases, that wasn't the case. That the powers that be, the ACIP, made the decision. We don't want to make changes. We're okay. We're doing okay on an overall basis. We don't want to rock the boat. What would happen if we made a change, stopped using the oral vaccine, went back to the injected vaccine because of this persistent phenomenon? There was a fear. What if we did that and then something went south? Finally, that decision was made, as I gathered from Walter Ornstein, during the committee meeting, the public meeting, entering into the room were people who were on the receiving end of the vaccine-associated paralytic polio. That had an emotional impact. A decision was made to stop using the oral vaccine in this country. And in the little bits of line that are at the right-hand bottom of the slide, polio was gone. So, okay, that's that part of the picture. Also, the lore was, this is a rare phenomenon. It was a rare phenomenon. Most kids, this happened, depends on how one describes it, but on the order of several cases per million children that would be on the receiving end of this. But it was not rare that the virus would mutate. And as Dr. Racaniello points out, we now understand that every recipient of OPV excretes within a few days viruses that are more neurovirulent than the vaccine strains. Dr. Sabin did the best job he could. The mutations that attenuated the virus are point mutations, easily reversed. There can be recombination with other viruses in the intestinal tract to reverse the effects of the attenuating mutations. This is a common phenomenon. It's not rare. It is rare that it goes on to cause paralysis in a vaccine recipient or a close contact, but the reversion towards virulence is not a rare event. Okay, so something new was noticed, picked up in around to the year 2000, which was the outbreaks of circulating vaccine-derived poliovirus, causing polio outbreaks the same as would be caused by the circulating wild polioviruses. This was primarily seen with the type 2 polio, many fewer cases with type 1 and type 3. But this is another new introduction that with community spread, additional mutations would be accumulated, and these viruses were every bit as virulent as the wild poliovirus. This is a summary that puts things into perspective. Before any polio vaccines were introduced, there were about 600,000 cases of polio estimated globally, basically worldwide. By the time the Global Polio Eradication Initiative was set up and this effort was undertaken in 1988, the number of cases had fallen to about 350,000 in 125 countries. And then we get a listing starting in 2010 of the details of the number of cases caused by wild polioviruses, which by 2021 had been reduced to 6 cases in 3 countries. The number of cases caused by circulating vaccine-derived polioviruses, CVDPV, hovering in the low two-digit numbers, down to 5 in 2016 in 3 countries. But then what happened was that a decision was made. We have to take type 2 viruses out of the oral vaccine and go to a bivalent vaccine, try and stop the problem of this predominantly CVDPV type 2 phenomenon of circulating polio being caused as a result of the oral vaccine. In order to do that safely, there was an effort made to introduce IPV in countries that had not been using it in order to protect against the emergence of type 2 polio, CVDPV, when that component was removed from the vaccine, or circular continued problems with type 2 viruses. Things didn't go well. There wasn't enough IPV supply, administration, etc. So it wasn't the globe was not blanketed with protection against these circulating viruses, and the number of cases began to increase. So things were influenced heavily by the COVID epidemic, but it had started before that. The number of cases were rising. So by last year, we're at in 2021, it's 698 cases in 24 countries. As you can see, it had gotten down to 2 countries in 2017. Things have sort of begun to break loose. But then we have to take into account the third column in red, the vaccine-associated paralytic polio cases. And forgive me, there may be more easy than I have found it to dig up data about these. We have public acknowledgement of the first 2 columns, but it's hard to get data on the VAPP. There was a paper published by Plattis, Steveras, and Sutter in 2014, which gave really good estimates for how much VAPP there was in the world, and it was around 400 cases a year in those countries that were continuing to use OPV. So the notion was take type 2 out of the vaccine, introduce IPV, we'll get a reduction. Everything is on my chart. There may be better figures, but it's just an estimate, somewhere on the order of 300 cases perhaps a year. That's just a ballpark figure. Just using that figure, where we were last year, 99% of paralytic polio was caused by vaccines-associated or derived viruses. So I want to just address weaknesses of each of the vaccines. And one aspect of the live vaccine was hyped to be better with respect to all parameters. That wasn't the case everywhere. If we take Nigeria, for example, these are data from back in the 70s, and these are the percentage of children lacking antibody after 3 doses of live poliovirus vaccine at the top, according to the 3 different types. A lot of kids, after getting 3 doses of the oral vaccine, did not have antibody. Whereas those that received the inactivated vaccine, that was a much smaller figure. So for some reason, in at least that part of the world, the live vaccine was not working as well as the kill vaccine, despite the anticipation, so to speak. Same thing true in Afghanistan. These are 2018 data, and the blue segment in the right. These are the investigating the number of cases caused by wild poliovirus, and the blue segment is fully 1/3 of all of the cases of polio in Afghanistan caused by wild poliovirus took place in children who had received 7 or more doses of OPV. What's going on? I don't have a good answer for that, other than perhaps malnutrition enteropathy or interfering intestinal viruses of other sorts. There may be other reasons, but there we have it. There's a problem in at least some parts of the world where the live vaccine just does not perform up to snuff. There was in the 2013 edition of Vaccines, Sutter and his colleagues have a table that illustrates the effect of the different vaccines on excretion of intestinal viruses after an OPV challenge. And what was seen was that prior immunization with OPV get a 99% reduction in the intestinal excretion of those who were challenged with the attenuated vaccine. Those who had been immunized with the inactivated vaccine, there was a 95% reduction. So it was less good than the oral vaccine, as we had seen in that very first slide, in terms of intestinal immunity. It was going through my mind, and I think others, that, well, is that 5% or 4% difference? How significant is that? Perhaps the inactivated vaccine, as we saw in the Scandinavian countries, which we have to emphasize that there's some difference in the environmental factors in those climes and cultural conditions. The transmission of the virus is primarily oropharyngeal. In areas of the world where sanitation is less good, primarily fecal oral. So we have to deal with those differences. Israel answered the question in 2013. Israel had stopped using OPV, using IPV only, but there was an outbreak, so to speak, of WPV infections in Israel. In a fully immunized population with IPV, there were no paralytic cases. Children were protected by the antibodies in their bloodstream, but the virus still circulated. Okay, is in an era where we're focused on eradication, that doesn't do the trick. So we've got problems on both sides. Both vaccines have some issues, and how do we deal with this at this point? Well, one way of dealing with it is the development of a new OPV using codon deoptimization, a technique not available to Dr. Sabin, to stabilize the attenuation so that the viruses could not revert to a virulent form. The type 2 N novel OPV has been introduced, and if it works, amen, that's fantastic. If that can continue to immunize without creating new circulating vaccine-derived strains. As far as IPV is concerned, there's been some attempts or motions towards doing some things that would be in improving its delivery capacity, the microneedle patch. that's been worked on by Mark Prausnitz and his colleagues at Georgia Tech. Again, for someone who is needle phobic as I was as a child, the idea of having a little patch put on your arm that can be taken off, or if you're a Rotarian wanting to deliver vaccines in a convenient way without trained medical personnel, the ability to do something easily like that. So that was something that was very appealing to me. And the thought in my mind that perhaps there could be ways of using adjuvants that would improve the intestinal immunity or mucosal immune responses to vaccines administered systemically. This approach hasn't panned out for the moment, not because of inherent difficulties, but there wasn't as of several years ago, you couldn't get enough of the antigen to do meaningful tests because all of the IPV that was being produced was being used in the field. Also, tooling up for, as Roland Sutter has said at WHO, tooling up for large-scale use of this kind of procedure, that it was just financially that there were many disincentives. The approach is being tested now in clinical trials in Africa with rubella, with measles. We don't know what happens in the future. The adjuvant approach is not so far panned out. A recent trial with an adjuvant DMLT just didn't turn out to be promising with respect to its ability to increase intestinal immune responses. I want to just touch on communication aspects, especially perhaps following the preceding presentation. This is a online blog by Peter Sandman, who happened to be a roommate of mine in a pre-college program at Jackson Laboratories many, many years ago. Misoversimplification. A play on words from George Bush's use of the phrase that his opponent had misunderestimated him. So, communication accuracy standard. This is an excerpt from the Global Polio Eradication Initiative's 2011 Training Manual for National Regional Supervisors and Monitors. Question, are there if the question is posed to you, are there side effects from the vaccine, the oral vaccine? The answer, no. There are no side effects. Experience shows that if children develop diseases or symptoms after vaccination, it is a mere coincidence. They would have developed these diseases anyway, with or without vaccination. That's true, but it's not completely true. And it's not true for those who get paralyzed by the revertant viruses. This is a polio GPEI publication online, CVDPVs, questions asked. What are CVDPVs? A child cannot get CVDPV infection from receiving a polio vaccine. That's true, but that's a tautology. It's because of the definition. CVDPVs aren't contained in the vaccine. They are only obtained from virus circulating in the community. So that's true. A child can't do that. But what are the implications? Fiction versus fact, circled. A child can, so it's fiction that a child can be paralyzed from receiving OPV. That is wrong. That is just not a true statement. So this is March of 2022, and this is what the GPEI is putting out in recommendations for people reporting on poliovirus outbreaks. This is a Scientific American article from July 25th of this year around about the New York polio cases, questions about the live oral vaccine. And here we have in red a statement: the weakened form of the live virus in the oral vaccine cannot cause disease. Okay, and then we have the statement: the eradication of polio in the Americas, Europe, and Africa has been accomplished solely through the use of the live oral vaccine. I mean, what planet are we living on that these kinds of statements can continue to be propagated? All right, it's coming to a close. Just looking a little back historically at this is the Polio Wall of Fame at Roosevelt Warm Springs in Georgia. This was a 50th anniversary celebration. These are people who made significant contributions to understanding and laying the groundwork for and working on the development of vaccines and dealing with our being able to control this disease. My father and Albert Sabin were sort of the two protagonists in a sense, with widely differing points of view about how things should be handled. We're still living in the shadow of all of that nowadays. And these were the new inductees at that time in 2008, which was the Rotary, WHO, CDC, UNICEF, the Bill and Melinda Gates Foundation, of course, became global partners after that. So the effort to take these vaccines, do something with them, and get rid of polio, the people in the field taking care of the reality of the polio eradication program as much as, if not more, heroes, so to speak, than the initiators. So just to closing comments as far as where we stand now with eradication, this is really touch and go. There's so many problems that need to be overcome in order to get this job done. As far as the vaccine side of things is concerned, it would be wonderful if this NOPV would work. But again, there's a question mark here, because we've seen that the oral vaccine doesn't work very well in some parts of the world. And will NOPV be any better than the Sabin strains? I don't know that there's any reason to believe that that's the case. Will that be a limitation, or will the fact that if it's used broadly enough, will that overcome the fact that there are children who just don't get successfully immunized by it? Don't know. Would introducing IPV along with make a difference? It probably would. So these are questions that need to be confronted on a practical basis. And then just because we're going to be discussing the New York case, I just wanted to put in my own 2 cents here, in a sense, because I get questions directed to me. And I would just want to say we're now living in a situation where CVDPV is raising its head again. We've got it now in this country because polio, as we know, polio is anywhere in the world as long as there's transportation from one place to another. Should we be scared? We should be alert. I don't think there's a reason for panic. We're fairly adequately immunized in such a way that I don't think we're going to see resurgence of widespread epidemics in this country, as had been seen back in the 50s and earlier. But we should be cautious, of course. We need to immunize those children who have not been immunized, and I've had adults come ask me, do I need to be immunized? Depending on where you live in your level of concern, get a booster. Will childhood immunization still have persisted? It didn't in me in terms of polio antibody levels when I was tested by CDC and for a pending visit. I got a booster and the levels went through the roof. So my father's view was the immunologic memory is there. You'll be protected. Maybe it will, maybe it won't. If you're worried, get boosted. Thanks.
Dr. Schnabel-Rupert, if you wouldn't mind, Dr. Wasilek asked if he could go next in this panel. He's calling in virtually. He missed his flight this morning. Dr. Stephen Wasilek from CDC, speaking about global eradication and COVID-19. Thank you for joining us virtually.
I really wanted to meet the panelists, so I'm very sorry I'm not there. And I hope the audio is adequate. So next slide, please. I'm going to go quickly through some of these items and just elaborate a bit on what Dr. Salk said. Next, please. Next, please. So the next 2 slides indicate, the polio has been with us for a while. This is a Egyptian stele. Next, please. This is a rehabilitation ward in California during the height of increased cases in 50s. Next, please. And this is an overview of Polio 101, which means there are a couple points I want to take away. The first is on the right, that in fact, as a median, 3 doses of trivalent vaccine are less effective, and this is a median, in low-income countries, particularly in countries with very high enteric infection rates, and that included India, Nigeria, etc. So not just the routine doses are recommended, but a lot of extra doses, and we'll talk about that. The big thing to know, and I think you do, is less than 1% of infections lead to paralysis. So paralysis is what we're trying to prevent, but infection is what we need to prevent and stop. And for type 2, which what we're discussing, it's only about 1 out of 2,000 infections in susceptible people that lead to paralysis. And therefore, what our surveillance finds in terms of paralysis is only, as they say, the tip of the iceberg. And so you have to be very careful in considering this. And this gets into the sewage testing. Next, please. And I do want to point out, don't go back, but there are 3 serotypes, and each were distinct and each have different characteristics. And the vaccines have different characteristics. The pros and cons have been discussed by Dr. Salk a bit. Next, please. And the big problem were uncommon complications. He presented the global data, about 400 cases of VAP, vaccine-associated paralytic polio, globally per year prior to the cessation of type 2 use. And it's really greater than 95% types 2 or 3 because, in fact, type 2 is about 46% and type 3 is more than 50%. So it adds up to very small percent for type 1. And this is different than the VAP risks, where it's predominantly been issues of type 1 and 2. The circulating vaccine-derived polioviruses. Remember, this is not a problem of the vaccine directly, as opposed to vaccine-associated paralytic polio with rapid reversion. This is a problem of low coverage, allowing Sabin to become Sabin-like in prolonged circulation and ultimately revert to a virulent and fully transmissible vaccine-derived poliovirus that causes paralysis, the same as wild disease. And most of it is type 1 and 2. The type 2 vaccine has very few attenuating, and 3, have very few attenuating nucleotide substitutions, and that's why reversion is possible for both of these settings, but the transmission is the one we'll focus on. Next, please. So I forgot this was animated. Everybody should be vaccinated. This is a very lofty goal of which we are not reaching globally, and I'll get into that later. Next. We have to supplement whatever is given to a child with additional doses to make up for children who don't get vaccinated. And the problem is not that the vaccines are failing. In other words, you do need multiple doses to have best seroconversion with Sabin vaccines. But because of that, you overcome that with supplementary doses in campaigns, either national, subnational, very targeted. And yes, so the issue is it is not a perfect vaccine, clearly. Next. Surveillance had been primarily looking for paralyzed children, testing stool specimens, and if there's a virus, characterizing it and genetically analyzing it, which can tell us a lot. A more recent date across the world, there's been more sewage wastewater testing. Because of this low ratio of paralysis, it's much more sensitive to detection. if you're testing the right places. Next, please. So some quick indication of where we went from when the polio eradication initiative was proposed and resolved by the World Health Assembly in 1988. And there, not all these were polio endemic countries, but were polio affected. The Americas had a target to eradicate polio by 1990. Their last case was in September 1991. Next, please. So by 2000, we were down, 2001, down substantially in the number of countries with continuing indigenous transmission of wild poliovirus. Next, please. And even further by 2006, next, please. But what we found were transmission that was country to country in neighboring countries. And I have called Nigeria a polio pump because they have shared their wild poliovirus with multiple countries multiple times. And there were distant introductions in several places. Illustrated here was from India to Angola. Next, please. Next, please. Okay, so we have made substantial progress, even though it kind of stagnated in the early 2000s. Next, please. The Americas were certified polio-free in 94. The Western Pacific region, these are WHO regions, was certified polio-free in 2000. The European region was certified polio-free in 2002. The last WPV2 case for type 2 indigenous was in 1999. It was certified eradicated in 2015. Next, please. And the Southeast Asian region was certified wild indigenous poliovirus free in 2014. Also in 2020, the African region was certified polio free. Next, please. So greater than a 99.9% reduction by now. But we went through a process of trying to improve the effectiveness of every opportunity to vaccinate children. So because the trivalent vaccine has competition for binding and seroconversion, type 2 being predominant, the program developed monovalent vaccines, which were not new. They had been used initially in 61 to 62 with type 1 predominantly. And because when you use type 1 predominantly in these endemic countries, you had a resurgence of type 3 for different reasons. And we had a seesaw effect for a while until the bivalent type 1-3 was introduced for campaigns in end of 2009 and used extensively from 2010 on. And you can see we got to 0 cases by 2013 of type 3 wild polio. It was declared eradicated 2 years ago, finally. Next. This is just an example of the waves of transmission that occurred. This is the middle wave. Nigeria had spread its viruses earlier in prior wave and it continued to circulate. There were more long-distance transmissions, and I just want to point out, relevant to current, Pakistan had its virus show up in China for a huge outbreak in 2010, affecting many adults. Over. Next, please. That's not over. Yes. Okay. So the problem was a bit of stagnation in reaching more children in endemic countries. And again, those monovalent bivalent vaccines were more effective per dose. But the problem was you still have to reach the children who weren't being reached in any case by routine immunization, and they needed more anyway. So we had a lot of countries with these imported outbreaks. Next, please. So I want to give you where we are currently. You'll note the New York case circled, and let me orient you, and I'll show this in greater detail soon, but the red dots are cases of wild poliovirus type 1 in 4 countries. And I'll show the chart close up. And a lot of vaccine-derived poliovirus in sub-Saharan Africa, and that is predominantly type 2, as we discussed. So next slide, please. Just to show the clarity of what I'm talking about and the countries and the fact that the USA is on the chart, there were no paralytic cases thus far in Israel or London due to what became circulating vaccine-derived poliovirus type 2. Next, please. And just to blow up, these confluence of dots, the current case count in Pakistan for 2022 is up to 19, and for Afghanistan is 2, and 6 cases in Mozambique. That's so far in 2022. Next, please. The problem of vaccine-derived polioviruses is a problem of low coverage with routine immunization, allowing Savin-like strains to circulate. And the predominant number of cases prior to 2006 were type 1, with a limited number of outbreaks. Not included here was a retrospectively diagnosed epidemic of type 2 in Egypt that was initially thought to be wild poliovirus type 2. So pay attention here. This is the number of cases that led to the decision to remove type 2 vaccine from routine use and campaign use. Next, please. So this switch from trivalent to bivalent was planned for all OPV using countries, preceded, next please, by introduction of at least 1 dose of IPV into routine immunization, and predominantly at 14 weeks. There were problems with supply. There were priority countries that received IPV. So the problem of emergence and spread, even if IPV had been fully given, is still not likely to have made a large impact on transmission. But the problem is always coverage and heterogeneity. So the switch occurred during April 2016, and ultimately, because of vaccine-associated paralytic polio and vaccine-derived poliovirus cases, we want to remove all OPV from use after certification. Next, please. So this is the full graphic showing the choice that the strategic advisory group, expert advisory group on immunization of WHO made the decision in 2014 to do the switch. However, there were problems, and we will talk about those problems in terms of how they occurred. Next. So there were a lot of assumptions and models. So the issue was at least 3 countries had circulating derived poliovirus outbreaks already occurring at the time of the switch, not found. So poliovirus surveillance was not detecting them, and that included many reasons, but it included Somalia, Democratic Republic of Congo, and Nigeria. The problem with immunity was routine coverage had been poor for years in Nigeria, for example, and so the routine administration of type 2 was low. They focused on using bivalent vaccine predominantly and did not administer campaigns of type 2 very often. And when they did some catch-up campaigns, they obviously did not reach those same areas where low coverage has occurred. And then the other problem with the switch is we had assumed there would be adequate supply, speed, and quality of outbreak responses. And this is been part of the problem. The quality has suffered, and I will get into that. Next, please. So to put in a graphic form of what Dr. Salk was talking about, while polio is no longer the predominant cause of polio paralysis, and it's been exceeded by this idea of stopping type 2 VDPV by stopping type 2 vaccination, exceeded by type 2 predominantly cases subsequently. The vaccine-associated paralytic polio has not gone away because of type 3 vaccines still being used, and some countries using IPV before OPV that drastically reduces the risk, next, of vaccine-associated paralytic polio. Next, please. So what we have a yin and yang of the effect of polio, the effect of the COVID-19 pandemic on the global eradication initiative and what happened with polio. So basically, apparently the decrease in mixing and interactions because of decrease in travel within Afghanistan and Pakistan severely decreased the apparent chains of transmission and led to a decrease in cases. Additionally, the COVID epidemics paused campaigns for a while until there were issues of protective equipment for our campaign teams, and they were restarted in June in these countries with limited quality because of still limited personnel who were available from COVID to move on, and that they still couldn't reach many children. But they actually improved their quality better than pre-COVID by mid-2021 in terms of the estimated number of missed children. Next, please.
Dr. Wasilek, we need to wrap up in the next 1 to 2 minutes, please.
I will then switch to the conclusion. Okay. Africa had a different problem. Their campaigns have never recovered from the pre-COVID, sorry for the spelling, pandemic. And that had been evident by the fact that SIAs in Nigeria in particular led to seeding of additional emergencies pre-COVID and during COVID, indicating very poor quality of the campaigns they were doing. Next, please. And then finally, the pandemic has affected routine immunization, and this is primarily disruption of health services and persons not coming to clinic, but also the shout around the world of anti-vaxxers has affected even routine immunization in some localities, not just some areas, not just COVID. Next, please. All right, next. All right, novel OPV type 2 was introduced. Next, please. Just a picture of it showing with red the changes that were made. Moving this segment to there made a big difference in vaccine safety compared to Sabin, and all these other changes stabilized it in terms of being less likely to revert in replication, in particular this high-Fi gene, which improves the RNA replicase. Next, please. So here's the issue. We have a problem with focus by countries on making polio a priority for some of these outbreaks. What we are doing is trying to improve local areas with the most difficult problems, all the partners, and we have to address insecurity, and it's been a chronic problem. So surprisingly, Afghanistan has been doing better, except in the north, with the default government in charge than it was because they were previously preventing campaigns in many areas. But there's also a funding problem. So the overall message I want to give is we can reach polio eradication, but we have a lot of challenges. And in terms of the IPV use in Western countries, it can stop poliovirus circulation, even if it's not effective as much as, say, in reducing mucosal fecal spread. Next, please. That's it. Thank you.
Thank you, Dr. Wassilek. Our next presenter is Dr. Patricia Schnabel-Rupert from the Rockland County Health Department, speaking about the recent case in New York.
Good morning, everyone. So I'm going to talk about our case. Starting July 18th this year, a case of paralytic poliomyelitis was confirmed in an unvaccinated young adult in Rockland County, New York. The infection was not travel-related. One case of paralytic polio is considered an outbreak, and in this case indicates underlying polio transmission in the community. Polio, and I'm not going to repeat a lot of what was said before, I'll just go through it quickly, is a vaccine-preventable disease caused by 3 different serotypes, as you know, 1, 2, and 3, very contagious, can spread from person to person through contact with feces, and then also with oral droplets. Most infected people, as you know, about 75% do not show any symptoms, and less than 25% do show mild viral symptoms that we can confuse with any other viral illness. About 1 out of 4 will have those flu-like symptoms, and about 4% meningitis. And the numbers you saw earlier related to each type that we see paralytic cases. So what this means is that 1 case is the tip of the iceberg, as already been mentioned. So as you know, it's an enterovirus. It persists in the throat for approximately 1 to 2 weeks after onset of illness and is excreted in the feces for the average of 3 to 6 weeks, sometimes longer if the patient is immunocompromised. Infectious people are most able to transmit during the days immediately before and after the onset of symptoms. People that are exposed to polio are at risk for non-paralytic poliomyelitis 3 to 6 days after exposure, with paralysis occurring 7 to 21 days after exposure. So I'll go to our case very quickly that we were notified the evening of Monday, July 18th, then by State Health, who had been notified by CDC after testing was done on a stool specimen on a patient who had been hospitalized with what they first thought was acute flaccid myelitis. This was, as I mentioned, an immunocompetent adult who was unvaccinated and from an insular community in our county. So at that time, a joint investigation and response was initiated by all 3 levels of public health. As of August 5th, poliovirus has been detected in samples of sewage water in our county, as well as in, so that's Rockland, as well as in Orange County, Sullivan County, New York City, and Nassau County, all in the southeastern portion of New York State. Testing has shown through genomic sequencing and evaluation that this has probably been circulating for up to a year. So if you look at the figure here, it just shows the timing of our wastewater results. And of course, we had the wastewater from our evaluations of COVID, and we went back historically. And now we're, of course, currently checking specimens as well. And we found that the Sabin-like type 2 poliovirus was detected in wastewater in Rockland and in Orange 25 days before and 41 days after onset of symptoms. That number is actually, this is from the MMWR that we had reduced back in August. To date, we still have weekly positive samples of wastewater for polio. And then you can see on here that the patient attended a large gathering on day -8, 0 onset of symptoms, and then the limb weakness on day 3. He visited, he or she, we don't identify as you know, so she or he, visited the emergency department and was admitted to one of our hospitals, and the specimens were positive on dates 11 and 12, with the patient discharged to rehabilitation on day 16. So background for that, the last case was in 1979, as is known. WHO, Region of the Americas, declared polio free in 1994. This is the second instance of poliovirus community transmission in the United States since 1979, and the first instance since 2005, and that was a type 1 VDPV. So it can appear when live attenuated polio vaccine is given to a population with low vaccination coverage, as in our case. I will review that. And the OPV was removed from the routine immunization schedule, as you know, back in the year 2000. Only IPV has been used since then. So for our public health response, of course, it's a joint case investigation. The New York State Department of Health put out an advisory to raise healthcare provider awareness. We have enhanced public health and clinical surveillance, wastewater surveillance, as well as syndromic surveillance. We've made an assessment of the vaccination coverage in the patient's community and surrounding communities. We have outreach and supplying of IPV to Rockland County providers. We've launched vaccination clinics in Rockland County on day 4. We were notified on the 18th, and by the 22nd had those pods up and running. And we are at present beginning to perform school and daycare audits as well. So this is a long-term collaborative effort by all 3 levels of public health. CDC has already promised, and we're very grateful that they will stay on board with us for 6 to 9 months, and New York State is totally supportive of that as well. About 5,000 letters were sent to families in Rockland whose children were under-vaccinated or unvaccinated. There's been an urgent plea for vaccinations signed. It was a letter signed by CDC Director Dr. Walensky, by Rockland County Department of Health, myself, and New York State Department of Health Commissioner Dr. Mary Bassett. Should have put them in better order, CDC, then state, then me, sorry. Okay, so for wastewater surveillance, those samples have continuously been evaluated. You can see on here, now this is again what was known back in August, and they do continue. So the effort was led by New York State in partnership with local, national, and global public health authorities. Environmental surveillance tool was used to help assess the spread of polio in our communities, and previously stored samples were evaluated. We were very grateful to have them and get them going. And as of the end of August, sequencing analysis by CDC confirmed existence of poliovirus in 43 positive samples. As of September 14th, we've had positives in 89 samples were tested. We continue to test now upstream samples as well. And wastewater samples from Rockland have genetically been linked to the United Kingdom and to Israel, though they have not had any paralytic cases there. There's been a New York City positive in Coney Island, which was not linked to us, and there were other positive sequencing. That was inadequate, so it's very hard to say. But others were linked to Rockland County, as is mentioned, Orange County, Sullivan County, et cetera. So for our Rockland County polio vaccination rate by zip code, you can see that in the red and the brown colors, they are very, very low. All of Rockland County, the rate is about 60.1%. In New York State's almost 80%, 79 point something percent. But in our zip code of 10977, it's 57.1%, and in 10952, it's as low as 37.3%. And these are in children under 2 years old. Those are the numbers we have from NICES. And again, this did occur in an insular population in Rockland, where there is a large population of very, very young children. The average age in the Muncie community, for example, is 14.6 years, where the average age in New York State is 39 years. So we have a very young population who are under-vaccinated and many, many who are unvaccinated. So as mentioned, our vaccination efforts began at our clinics on July 22nd. As we all know, polio vaccine is the best protection against polio. And we have administered to date about 6,100 vaccines. 64% of those are in the 2 zip codes that I just mentioned. And they've been provided by Rockland County private physicians, by federally qualified health centers, other providers, our clinics. It is a joint effort to do that. As we know, 2 doses of IPV provides 90% protection, and 3 doses at least 99% protection against severe disease. WHO on September 13th this year added the United States to the list of countries with circulating vaccine-derived poliovirus, something we were hoping not to see, just as we were hoping not to see our measles outbreak 4 years ago, that we were able to end 6 days before we would have lost measles elimination status in this country. So that was a win. And so far, this is not a win. So prevention of polio by adequate vaccination is absolutely essential. I know I'm speaking to the choir, but I'm glad to share our case with you, and we can answer questions as you need. Thank you.
Thank you very much. Our next presenter is Dr. David Oshinsky from New York University, speaking about vaccine hesitancy regarding polio.
Thank you. Thank you, Dr. Dunn. I thought that was a terrific presentation. And the physician who asked the question about whether the current COVID vaccine controversy will impact traditional vaccines is the $64 question. That is the big question at this moment. And I'll try to address it a little bit at the end. So thank you. When you look at this particular slide, and Peter knows it very, very well, there's Dr. Sabin at the top, Dr. Salk at the bottom. This was one of the great moments in American medical science. I think public faith in science had never been higher and would never be higher in the future than at this particular moment. Vaccines were coming out. Antibiotics were rolling out of laboratories. If you looked at medical textbooks, and journals, they actually were encouraging medical students not to go into infectious disease. It's going to be conquered. We don't have to worry about it. Go into all kinds of chronic care and the like. And you realize how arrogant, given what has happened in the past 50 years, how arrogant that statement was. But I think it gives you really a sense of exactly where we were at that moment. As Dr. Salk knows, President Eisenhower invited his father, Jonas Salk, to the White House. And for the first time in anyone's memory, Eisenhower broke down in tears as he thanked Jonas Salk for saving the children of the world. We've come a long way since that point, and a lot of it has not been positive. Now, there were some issues. There was the Cutter incident right after the polio rollout, where due to sloppiness of certain companies, live virus was put into the Salk vaccine. There were many issues of paralysis. There was death. This was all on the West Coast. But epidemiologists from the CDC went out there and solved this problem very, very quickly. There was a sense at one point that the virus SV40 was in the vaccine and it might be causing cancer. As you know, Andrew Wakefield basically panicked us all when he came out with a study completely fraudulent, totally discredited, that basically showed a correlation between the MMR vaccine and autism. And as we know, there was a big push by the anti-vaccine group to claim that autism was part of the polio experience. Okay, what I want to show you here is in 2015 at NYU, we held a conference on vaccine hesitancy. And what you see, as you would expect, the anti-vax forces brought several buses, a couple of hundred protesters. For the first time, we took measures in security and who could get into the room. They were annoying, but we didn't consider them anything more than a fringe group at this time. And it was kind of a celebratory meeting because our main speaker was Dr. Richard Pan from California. And some of you may know that Dr. Pan is a pediatrician and a legislator in California. And he had just pushed through S-277 through the California legislature, signed by Governor Brown. And basically, it came out of the measles epidemic that had occurred in Disney World just before. And there was great fear about the spread of other vaccine-containable diseases. And what S-277 basically said was that anyone any child who went to a public school, a private school, or a daycare center had to be fully vaccinated against the 12 traditional, having all 12 traditional vaccines. And more than that, there would be no exemptions other than medical exemptions, and they would be seriously tightened. And this was an enormous breakthrough. And what is really interesting about it is there was an attempt to recall Senator Pan. It failed miserably. And the anti-vax forces in California actually tried to put a repeal referendum on the ballot, and they couldn't even get enough signatures. That is how strong the feeling was in California and elsewhere about really tightening up vaccine exemptions and making sure that the numbers stayed high. Fast forward now to almost the present time. Dr. Pan last year proposed legislation to add the COVID vaccine to the list of regular vaccines for children, and only medical exemptions would be given. It was supported by Governor Newsom, just like the original had been supported by Governor Brown. But there was so much pushback immediately, and we're not talking about fringe anti-vaccine groups. We are talking about the public as a whole, that they basically tabled this for some future point, and we're really not sure that this will ever come to fruition. I think when historians write about the transition from a small fringe anti-vaccine movement and real serious issues of vaccine hesitancy among the public, there'll be a very large discussion of the Trump administration. And for obvious reasons, I'm not going to get deeply into this, but there certainly was a fear when Trump was elected, having made statements about autism and vaccines, having invited Andrew Wakefield to one of the inaugural balls, and worst of all, allegedly promising RFK Jr., a conspiracist, to lead a vaccine safety commission. And that made everyone nervous, to put it mildly. In fact, Trump backed off on all of this. He never had anything to say really about Robert F. Kennedy after that, RFK Jr., who was furious about this. There was no commission. Trump took his annual flu shot, a presidential tradition. When a measles outbreak erupted in 2018, he urged parents to get their children vaccinated. And of course, there was Operation Warp Speed. His administration's role is obviously very controversial, but it opened government coffers for research, development, and the manufacturing of the vaccines. It used the Defense Production Act to open the pipeline for vaccine makers. It gave vaccine makers full protection against lawsuits. So what you have here, I think, is sort of an interesting dichotomy. And at this point, vaccines were seen as widely successful and they were widely accepted. Administrations changed and mandates followed. And suddenly, a large part of the population that supported President Trump and did not really have major questions about the vaccine, suddenly issues of freedom of choice, charges regarding vaccine safety, took on a real political persona. Now the government was lying to us. It was feeding us false information. It was constantly changing the guidelines. And the center of that battle involved, COVID vaccines for children. If you look at this, you can see it says more than 4 in 10 parents of children under 5. This is from July 2002. For the vaccine say they will definitely not vaccinate their child for COVID-19. And you can see just looking at the chart that the numbers of those who are saying they're going to get the vaccine for their children are diminishing, as well as the number of people who say they will get them vaccinated right away. In other words, we are now moving in the wrong direction when it comes to the vaccination of children for COVID vaccine. Let me go a little bit further. Here are, and this was done by Kaiser, here perceived, basically, what are the reasons you are not vaccinating your child age 6 months to 4 years, getting the COVID vaccine right away. And you can see that too new, we're worried about side effects, safety concerns, they don't need it, they're too young, let's wait and see, it doesn't work, it's not effective, etc. And what I would say to you is that there's some truth to this. In other words, parents read the papers and they saw that the rollout of the Pfizer vaccine in early 2022 for children was not especially successful. You know, if you sort of looking at 90 to 95% rates early on, you're now looking at rates of 30%. And you're looking at immunity dropping very quickly within 2 months down to 15%. You also have parents who are basically saying children don't appear to be in a high risk category. You know, why basically should I take any risk at this particular point? Vaccines are always a matter of risk versus reward, including the polio vaccine. But when it comes to the COVID vaccine and the vaccine that has been rolled out, and when parents look at who is most at risk for COVID, what you basically begin to see is that these kinds of fears are basically pretty legitimate. Let me go down one. I'll come back to that one. There's my boy Wakefield. The final is nearly 2/3 of Republican parents and unvaccinated parents say they will definitely not vaccinate their young child for COVID. The party identification is interesting, but even when you look at Democrats or Democratic leaning, the numbers are very, very small. Now, it's obvious that parents who have been unvaccinated themselves and lean Republican are more unlikely to get the vaccine for their children. But it's also quite obvious when you look at this that very few people at this point are basically immunizing their children 5 to 11. It's just not happening. Now, let me go back a little bit if I could. All right. This, Doctor, looks to your question. This is from the Defender, which is RFK Jr.'s, one of his publications. And it's really scary because the headline is a COVID silver lining, more parents than ever questioning routine child vaccines. And that, I think, is a real problem that we are facing. And when you look at what is in there, the polio vaccine is very high among them. And Doctor, what they are really saying in some cases, oh my God, it's a single case. There's no sense that, as you said, there are lots of silent carriers and the like. It's a single case. What are we worrying about? You're just scaring people to get vaccinated with a vaccine that, in fact, may cause polio. It's those kinds of things that are getting out there. And what I think we really have to worry about at this point is what will happen. I think the rollout of the COVID vaccine for children was basically a disappointment, and whether it leaches into the other traditional vaccines is an open question. Let me just end by saying this. Recent figures show about a 1% drop in routine vaccinations this year for kindergartners. That's a very, very small drop, and it's a good sign. And obviously, vaccines, the number of kids who got vaccines really declined during COVID because they weren't going to doctors for regular checkups and the like. So what we're seeing is it's slightly below what it was before COVID, but at this point, at least nationally, it seems to be holding up pretty well. 20 states, all with Republican governors, through legislation or executive order, have banned vaccine mandates for COVID. Will this apply to regular vaccines in the future? Will it lead to more generous exemption policies? I don't know. But it really is something that we have to take very, very seriously. Let me end with Mississippi, which is one of the oddest states imaginable when it comes to vaccines. Mississippi has some of the worst health outcomes in the United States, including the highest child mortality rate. Yet it has the highest vaccination rate of any state in the country. It's over 99% now. At this very moment, and I'll just take a minute to explain that, at this very moment, it also has the lowest rate of COVID vaccination among adults and children. There is this remarkable dichotomy where to this point, the low rates of COVID vaccination have in no way leached into the very high percentage of kids who are getting vaccinated. Why were kids getting vaccinated and are still being vaccinated at such a high rate in Mississippi? For generations, its courts basically said that mandates for vaccines were legal. They went back to the Jacobson case in 1905. And they adhered to this so that public health trumped sort of parental choice. And Mississippi basically followed this. It's one of 2 or 3 states that only has medical exemptions, no philosophical exemptions, no religious exemptions. What you're beginning to see now, however, are legislators in Mississippi starting to produce bills that deal with mandates and larger, more generous exemptions. To this point, amazingly, Mississippi is one of 8 states with a Republican governor that has not banned mandates. And what I would say to you is that if you want to look for a bellwether, look to Mississippi and stay tuned. And if I were to try to impress upon you what I think is the most important single issue we face now, it is the protection of traditional vaccines in the face of higher resistance, particularly against the COVID vaccine. Thank you very much.
I want to thank all of the members of this panel. We're running a little over, but I think we'll take time if there's one quick question from a member of the committee here or online. And while we're looking for that, just to let you know, I'm going to reorder things just a touch. When we finish with this question, we'll move on to the next panel, and we'll take our break after that panel from timing. Rob Schechter, please.
Thank you, and thanks to all the speakers for your presentations. I'm wondering, in the delivery in Rockland County, whether you're seeing any effects on hesitancy, either from the case itself or in your communication methods, any of the tools that are being suggested in the subcommittee's report. Is anything making a dent? And in the thousands of doses that have been given, what percentage rise in coverage would that represent?
As far as the hesitancy, yes, we are seeing, we have a lot of infiltration of especially our insular community in Rockland by the anti-vaxxers. And we are now working to supersede them, if you want to say, as best we can. It's going to be very, very difficult. They have robocalls nightly on the phone. We had been part of, like, listening in on part of them, not to speak, back to measles. This is not new. And I understand what Dr. Oshinsky's saying about, COVID and the effects, but truthfully, this was going on for years. This is way before COVID. COVID made it worse, but it's been going on for many, many years. And it's a very large challenge for us to be able to provide the correct information and correct the myths. And you want to talk about Bobby Kennedy? So he sued me back at measles time because I put forth legal requirements for the children to stay home if they weren't vaccinated. So just as an example, by the way, we won, but but this is ongoing. This is not new. It's going to have to take long-term strategy to improve. As far as our vaccination rates, we had an increase. I actually have a graph here. I don't know if you'd be able to see it from this far, but we had an increase in our rates of vaccination after the July 21st information was presented about our one polio case. It's, like we said, tip of the iceberg. And we also try to educate in that regard as well, that this is what it is. There's not just one case out there. But anyway, but as you can possibly see, we've gone sort of back to the baseline already. So to give you the exact percentage, I don't have that number with me today, but I can tell you that it's unfortunate that we haven't sustained that level of increased immunization in the areas that we need. We have a lot more work to do, and we will take this challenge as an opportunity and continue to do that. But if anyone has any ideas, we're grateful for them. This is going to be ongoing.
If I could just add, and thank you. If I could just add one thing. After Governor Newsom and Senator Pan basically put this forward, other municipalities and particularly school districts did the same. In other words, they mandated COVID vaccines for their students. Virtually all of them have pulled back now. Virtually all of them. In New York City, they pulled back to athletes and people in the choir. And God knows how that will work out. But my sense is they just don't want to get involved in the culture wars. It's just the pushback is so hard that they just feel that they're caught in a maze here, and it's really impacting them and their students.
And our last comment or question from John Douglas online.
Thank you, Bob. I had a similar question for Dr. Rupert. The Vaccine Confidence Report calls out identifying trusted local community leaders, and I'm wondering in your insular communities if you've had any success with that, as they've seen, first measles and now at least the one polio case. Any sign of their changing how they message to those who trust them?
So it's unfortunate that we lost some of our community liaisons from measles to date. And the reason for that, from what we were told, is that they, like me, had received some death threats. And so they've pulled back. And that's been a major problem for us because those people that we counted on, 3-4 years ago are no longer available to us. So we are now working with newer community groups, and hopefully we will have additional liaisons coming forth. The problem we have in the county also is that we have a very heterogeneous population. And of our ultra-Orthodox population, there are a number of different sects. There is not one leader of the group. The other, I'll say quickly, is that it's the moms. It's the mothers that make the decision on vaccines for their children. We learned that in measles. We all know that now. We've discussed it ad lib. And again, the problem is there is not one matriarch, if you want to call, in the community. So we are working with a variety of different community providers, liaisons. Midwives have been very helpful to us as well. There's a female Jewish women's organization, a medical organization that's been helpful to us. So we've had to reach out to a number of different organizations versus one or two liaisons that we've had. Thank you.
Thank you.
And I want to once again thank our panel. It's been very informative and interesting. And thank you again for your time.
Thank you.
Produced by the U.S. Department of Health and Human Services.